following is a demonstration of our technique for the use of a percutaneous posterolateral portal used for arthroscopic repair of a shoulder posterior labral tear. These are our disclosures. The patient is a 33-year-old male who began experiencing left shoulder instability episodes after a car accident. He did not report any frank dislocation episodes, but felt his shoulder subluxing posteriorly on several occasions. He reported pain with push-ups and bench press as well as overhead activities. He completed physical therapy and other conservative treatment without relief. Examination of the shoulder demonstrated full active and passive range of motion and full strength on rotator cuff testing. Special testing was notable for positive jerk and grade 2 laxity with posterior load and shift testing. Selected MRI cuts demonstrate a posterior labral tear without significant glenoid dysplasia or glenohumeral degenerative changes and no signs of rotator cuff pathology. The patient is placed in standard lateral decubitus position and an arm holder system is used to secure and position the upper extremity. A standard posterior portal followed by an antero-superior and antero-inferior mid-glenoid portals were made. After diagnostic arthroscopy is performed, a curved labral elevator is used through an 8.25 by 7 mm cannula in the mid-glenoid portal to elevate the labrum and capsule, followed by an arthroscopic shaver to prepare the glenoid surface for healing. Following a diagnostic arthroscopy and preparation of the glenoid and labrum for repair, the arthroscope is switched to the antero-superior portal and attention is turned to establishing the percutaneous posterolateral portal. This portal is typically about 4 cm directly lateral from the posterolateral border of the acromion and is often in line with or inferior to the posterior portal. A 17-gauge spinal needle contained in the percutaneous kit is used to localize this portal under direct visualization and confirm satisfactory angle for anchor insertion. If the portal is too medial or parallel to the glenoid, this increases the risk for damage to the cartilage when drilling for the anchor. Once the portal location is confirmed to be satisfactory, a nitinol wire is placed through the spinal needle and the spinal needle is removed. A small 3 mm incision is made over the nitinol wire and a cannulated switching stick is placed over the nitinol wire. The nitinol wire is removed and the drill guide for the anchor is placed over the switching stick. The anchor is drilled and a 1.8 mm all-suture knotless anchor is first inserted into the glenoid at the 6 o'clock position through the drill guide in the percutaneous posterolateral portal. An 8.25 mm cannula is advanced into the joint through the posterior portal, and a 45-degree reel pass suture lasso is used to shuttle a number 1 monofilament suture through the capsule and labrum. A knotless repair is then performed using standard suture shuttle technique and tensioned appropriately. Once the knotless repair is adequately tensioned, the suture is retrieved through the posterior portal using a looped grasper and cut flush with the anchor. A standard layered closure is then performed.